Welcome to this explainer. Today, we're diving into the fascinating and, honestly, quiet failure of the liver as we rebuild our understanding of chronic liver disease from the ground up. The liver is truly one of the most remarkable organs in the human body. I mean, it can literally lose up to 75% of its tissue and still function perfectly fine. But its failure is often completely silent until it reaches a critical breaking point.
Picture this. You've got a patient whose blood tests have been perfectly normal for years. Then, what feels like completely out of the blue, they show up in the clinic with a swollen abdomen, spider-like blood vessels radiating across their chest, and a sudden onset of confusion. So you gotta ask yourself, did this really just happen overnight? Well, it certainly looks sudden. But the reality is, the liver has this massive compensatory reserve. It's kind of like a phone battery that deceptively reads 100% all day long and then suddenly plummets to 0 in 2 seconds. By the time we actually see these visible signs of failure, the organ has been failing quietly for a very, very long time. To truly understand this disease, we have to understand exactly what that failing liver can no longer do.
Okay, let's jump right into part 1. Engine 1, lost liver functions. Let's look at the first engine driving this disease process, which is the liver's lost synthetic and metabolic functions. Chronic liver disease is essentially the progressive replacement of healthy working liver tissue with useless fibrous scar tissue. And this chart right here, it brilliantly illustrates that the physical stigmata we see on a patient aren't just some arbitrary checklist you have to memorize. They are a direct, logical map of exactly which liver function has failed. A healthy liver normally clears circulating estrogen. A failing one can't. That resulting hyperestrogenism dilates small vessels, giving us spider nevi and palmar erythema, and alters tissue, causing gynecomastia and testicular atrophy. What about leukonychia, those white spots on the nails, and low albumin? That's simply failed protein synthesis. Bruising, that's the liver's failure to produce clotting factors. Basically, every sign on the skin is just a lost liver function made visible.
All right, moving on to part 2. Engine 2, portal hypertension.
Running right alongside those lost functions is our second engine. Because the fibrosis, the scarring, it doesn't just impair the liver cells, it physically distorts the liver's entire architecture. This physical roadblock obstructs the blood trying to flow through the liver, and that causes the blood to back up into the portal venous system, creating a really dangerous condition known as clinically significant portal hypertension, or CSPH. So the crucial point here is exactly how we measure this danger. The defining threshold for clinically significant portal hypertension is a hepatic venous pressure gradient of exactly 10 millimeters of mercury. Once that pressure climbs just a bit higher, above 12 millimeters of mercury, the risk of a dangerous, potentially fatal variceal hemorrhage shoots right up. It's a tipping point, for sure. And this elevated pressure perfectly explains the second cluster of clinical findings we see. We get splenomegaly because blood is quite literally backing up into the splenic circulation. We see ascites because that immense pressure forces fluid right out of the engorged splanchnic vessels directly into the abdomen. And we get those dangerous portocaval anastomoses, varices in the esophagus, stomach, and anal rectal areas because the blood is forcibly rerouting through smaller collateral vessels that were just never built to handle that massive volume of flow. Which brings us to part 3, causes and epidemiological shifts. So what's actually causing these two engines, the lost function and the rising pressure, to fail in the first place? Looking at the global landscape, we're seeing a massive shift. While classic causes like Hep C and alcohol obviously remain leading drivers, NAFLD, non-alcoholic fatty liver disease, is skyrocketing. It now makes up the largest proportion of what we used to just call unexplained or cryptogenic cirrhosis. And what makes NAFLD particularly tricky is that it rarely produces those classic dermatological stigmata we just mapped out. You can actually have a metabolically driven cirrhotic liver that looks deceptively unremarkable on a standard skin exam.
Okay, part 4, grading severity.
Once we recognize the disease, we need to logically grade just how badly this organ is failing. To do this, we rely on two distinct but highly complementary scoring systems. First up is the Child-Turcotte-Pugh score. It uses 5 parameters, encephalopathy, ascites, bilirubin, albumin, and prothrombin time, to give us a really broad functional snapshot of the liver. It grades severity into 3 classes. To put why this matters into perspective, a patient's 1-year survival drops from over 95% in Class A all the way down to roughly 50% in Class C. Then we have the MELD score, along with the modified MELD-NA, which factors in sodium. The MELD score is much more granular. It predicts exact mortality and directly drives transplant prioritization. In fact, a MELD score of 15 is the official critical threshold for referring a patient to a transplant program. Next up is Part 5, the 2024 treatment paradigm shift. This is where things get really interesting.
So let's talk about treatment, because there's been an absolute game changer recently regarding that second engine, portal hypertension. The old school teaching was to formally confirm cirrhosis and then essentially just wait around to see varices on an endoscopy before starting beta blocker therapy. But the 2024 AASLD guidance completely tossed that out. They introduced the concept of compensated advanced chronic liver disease. It ditches the need for a formal cirrhosis diagnosis and instead uses non-invasive markers, specifically transient elastography paired with a simple platelet count, to catch that pressure early and start non-selective beta blockers immediately.
This isn't just some minor incremental tweak, guys. This is a fundamental paradigm shift in how we approach liver disease. By starting non-selective beta blockers based on non-invasive markers, the explicit goal is to intervene on the pressure itself earlier to completely reduce the risk of that very first dangerous decompensating event from ever even happening. Let's move to Part 6, managing complications.
But despite our best efforts, complications do eventually pop up. And when they do, their management logically ties directly back to whichever of our two engines is causing the trouble. For ascites, which is driven by high pressure and low protein, we use sodium restriction, diuretics, and for refractory cases, a TIPS shunt that directly tackles the pressure gradient itself. For spontaneous bacterial peritonitis risk, we use long-term norfloxacin prophylaxis. For hepatic encephalopathy, driven by lost metabolic function, lactulose is the go-to. It brilliantly acidifies the colon to prevent ammonia absorption and speeds up transit time. And for the 3% annual risk of hepatocellular carcinoma, we absolutely rely on dedicated 6-monthly ultrasound screenings.
Oh, and a super quick but absolutely critical safety note here. NSAIDs and ACE inhibitors are strictly avoided in these patients. Why? Because in a circulation system that's already incredibly hemodynamically strained by portal hypertension, throwing these meds into the mix can very quickly precipitate severe renal impairment. Just stay away from them.
All right, bringing us to Part 7, transplant and emerging tools.
Finally, when the liver's compensatory reserve is completely wiped out, we have to look at the ultimate intervention, transplantation, and an amazing new pharmacological tool that helps patients safely get there. When the liver completely fails, a transplant is indicated by these criteria: a MELD score of 15 or higher, recurrent ascites, variceal bleeding, severe encephalopathy, or hepatorenal syndrome. That is, of course, provided there are no major contraindications like active cardiopulmonary disease or ongoing substance use.
Getting these patients through necessary procedures safely before transplant can be notoriously risky due to poor clotting. But we have a genuinely awesome new tool in our arsenal called a vatitrombopag. It's an oral thrombopoietin receptor agonist. Instead of just passively relying on platelet transfusions, it's used to directly raise their platelet counts before a scheduled procedure. It tackles the bleeding risk right at the source.
So let's run through the logic one more time to really cement this. First, view the disease as two parallel engines. Map the physical stigmata straight back to the liver's lost synthetic and metabolic functions. Second, trace those severe physical complications to the architectural roadblock of portal hypertension. Grade it logically with Child-Pugh and MELD. And third, and this is absolutely crucial, shift your mindset to treat that pressure early using non-invasive markers, exactly as the 2024 guidelines recommend. So what's the big takeaway here? Next time you see a patient with spider naevi on their chest or a fluid-filled umbilicus, don't just name the physical sign and move on. Pause and ask yourself this exact question: which rising pressure or which lost liver function actually put it there? When you answer that, you turn a memorized medical checklist into genuine first principles understanding. Thanks for joining me for this explainer, and I hope this completely changes how you look at chronic liver disease.